Good morning, everybody. I'm very much thankful to the Scientific Committee Chairman, Dr. Partho Viswas, and the organizing committee to giving me an opportunity for the instruction course 121, that is the Empower Yourself by Decoding the IOL Power Calculations. We have very esteemed faculty for the instruction course. We have Dr. Tejas Shah, Dr. Arshul Tak, Dr. Sail Vasavada, Dr. Somil Kothari, and myself. We all are practicing nearly more than 15 to 20 years for the cataract surgery. All are the very leading faculties in this field and they are all speaking on the national and international forum for this talk. So we start with our talk. Dr. Arshul is a little bit late, so I am starting with my talk. The decoding the newer generation IOL power calculation is implication. Now, in cataract surgery, there was a good visual outcome at 2000. In the era of 2010, in the next decade, it was a good refractive outcome. But now the demand of the patients are the excellent refractive outcome. So we have so many updated instruments, and we have already one talk for this, updated all these optical biometers by Dr. Arshul. But the updated instruments give the very precise and axial length and the measurement of the keratometry, which is very much precise with these newer generation machines like Galileo or IOL Master 700 or Color LED. All these machines give us very good precise anterior and posterior corneal power calculations, and then gives the total corneal power. So we have a very good excellent measurement, we have very good corneal measurement, but even though we are getting so many refractive surprises, and by the source of error, the magnitude at present, the 76% of the cases where the ELP is the one of the main culprit for the source of error. So all the formulas which are at present focused is based on the find out how to go for the good effective lens position calculations. So now the classification of the IOL power calculations from the historical based method to the regression based method. Now the Vergen's formula, which is based on the Gaussian optics, they are using the different variables. Variables like the two variables like anterior chamber axial length and the corneal power. 3 variables, they are considering the anterior chamber depth. 5 variables, they are considering the lens thickness and the white to white by the Barrett universal. And 7 variables formulas which are using the preoperative refraction and the age of the patient. So this is nowadays the accuracy or range of the commonly used formulas up to the 5 years back. That was the all third generation formulas like Oladevan, OFER-Q and SRKT, and you modified according to the axial length by the Wong modification. You can get better results with the normal anatomy. But the patient have all other type of anterior segment anatomy like small eyes or a small anterior segment with the normal axial length. In such cases, the newer version of the IOL power calculations, they works much better, particularly Barrett formula, Olsen formula, Hill RBF formula. So all these formula based on the ELP estimation, and the predictors which newer generation formulas which are taking is the lens thickness as one of the main part as a variable, and certain formulas which are considering the cornea part for the better keratometry measurements. They are considering the corneal asphericity and the posterior anterior ratio like a panacea methods. So in 2022, so many formulas we have. From left side, there was our old third generation formulas. Now in the 2015-17, we have Barrett 2 Universal and Olsen, but now we have plenty of formulas which is available. At present, the current and all these formulas are available online without any charge majority of them. So we have accessibility of all of them, but how to go for it? At present scenario in world, the top formula which is commonly used is the Barrett Universal 2, Ken formula, EVO formula, Hill RBF calculator, Olsen formula and panacea calculator. But most important part, without any regular optimization of their performance, no one is superior than the traditional formulas. So we go for each of them individually, which are the key factors for the why this formula is more important for the newer power calculations. One is the Barrett suite. Barrett suite has a 3 component, which has a non-toric component, which is a Barrett Universal 2. It has a toric component, Barrett toric, and post-refractive surgery, Barrett 2K. which is available in majority of the optical biometer. It is a theoretical model generation formula. Most important thing is that it is a thick lens formula. So it is based on the IOL model like a high meniscus lenses. And for the Barrett toric formula, toric IOL theoretically takes account by the posterior surface of the cornea. So you can use both the actual measurement of the corneal power and you can go for the nomogram method. Barrett suits has also two types of factors. One is the lens factor and one is the design factor. This lens factor is given by the Barrett for the individual IOLs. But the design factor is very much important because it gives the lens transition from biconvex to the meniscus. So when you are going for the operating any patient who has extreme high myopia, then the design factor has to be changed in the Barrett formula. This is inbuilt in the majority of the Barrett formulas. APA CRS website, this is very much easily available online. You can go for it. Here they have added two more things. One is Barrett treatment formula. So post-refractive surprise you can manage very well with it. And Barrett TrueCat toric calculator, which is incorporated now. That is mainly used for the patient who have been undergone the pre-refractive surgery with the toricity, residual toricity, and you can correct that with the toric IOL. The Hill RBF calculator is again newer artificial intelligence formulas. They are artificial intelligence with a machine learning pattern recognition and data interpolation. That is known as adaptive learning. And this uses the 3-point database of the corneal curvature, antechamber depth, and axial length. And this has been already fed with the measured by the optical biometry, and this gives a results of the by artificial intelligence. Recently, Hill RBF has again extended beta version introduced, and the 3.0 version is also been introduced, and they have a data set of the more than 1,000 high hyperopic and high myopic patients, extreme high hyperopia and extreme high myopia also. So there gives a much better results with the artificial intelligence in a high hyperopia or high myopia. I think the next speaker is taking how to deal with the high myopia and high hyperopia. Another formula is a LADA super formula. It is also based on the artificial intelligence, but the important part in this LADA super formula is all these versions formula or ray tracing formula, they are a fixed base equation. You put your patient data, you have an equation, and you are getting the output. So it is a fixed one. It is a static formulas. Like our AI artificial intelligence formula, like a Hill RBF and Clark, is a data set limited. So whatever the data has been there, artificial intelligence capsulated it. But the LSF means LADA super formula, which is an evolving formula. So whatever the at present level, it is online updated every time. So it is a real-time formula. So whatever the data at present world is getting it is already updating by itself. So it is an artificial intelligence which is updating on itself by its own. It's a real-time one. So it gives this graphical presentation in LADA super formula. And another important part, the next version of LADA has introduced the refractive index inclusion. So device refractive index inclusion is very much important. Why? Because our measurement of the cornea is mainly based on the corneal curvature, corneal power. But all the gauges which are giving the curvature power, not the actual power what we are putting in the IOL power calculation. So suppose your corneal curvature is 7.3. The one machine has considering the refractive index of 1.3375, another machine is considering 1.3337. So both are the giving refracting index and both are giving the different powers. So this thing has been taken care by this LADAS formula. The LADAS has also given a formula in such a way that it can be incorporated in the optical biometer. So now our optical biometer is also smart, like our smartwatch. So whatever though you are operating the patient, you are getting the results. That result has been automatically fed in the optical biometer, and that will be automatically corrected in the next patient. So this formula is now evolving in such a way that our optical biometer is going to be smart in the next future. Another is a Panacea calculator. The Panacea calculator, which is available online, and every NTS segment has to be download this calculator, because it is not only helpful for the IOL power calculation, but it is helpful for the management of the glaucoma patient, keratoconus patient, refractive surgery, how much residual bed will be there. So everything will be given by the Panacea calculator. So it is very useful tool to download for the NTS segment surgeon. It also gives the toric calculator, SIA calculations, your surgeon A constant calculations, post-operative toric calculations, everything has been fitted in this calculator. So it is very useful tool for anti-segment surgeon. Now what it gives, not only the biometric data, it also have a topographic data. But topographic data it considered as a posterior anterior ratio and the corneal sphericity consideration in the IOL power calculation for this formula. Another important feature in this calculator is a selection of the patient for the multifocal or EDOF lenses. It gives the defocus curve. So you suppose patient have a more near vision or suppose patient wants a more intermediate vision, you can select which trifocal will be best for the patient according to patient's data, because it is considering the corneal sphericity, PA ratio, everything has been considered. So it will give the precise idea whether this patient fits for the visual IOL or a panoptics. So you can consider according to that. So you can get the patient's presumed bifocus curve for every individual lens. Another important part in the calculator is the capsular back tilt factor. So which is another important part in the toric calculations which is coming up, and we will talk regarding that in our last talk. Ray tracing technology. All third generation formulas are based on the Gaussian optics, that is a thin lens based formula. So cornea has a single plane, lens has a single plane, and we presume what will be the effective lens position. Now ray tracing analysis was not there at that time, but because of advancement in the instruments, we are getting each and every point of the cornea. And this point has to be exported through the ZIMAX type of optical softwares which are used in the telescope. So we are getting the very good corneal topography in such a way that we can use this data and considering what is the corneal power exerted at which level of the cornea. So ray tracing formula performs better where the effective lens position calculations formulas or thin lens based formulas are not working well, like abnormal corneas. Like scarred cornea, corneal sphericity is not good. In such conditions, I think Dr. Thesis is talking the talk how to manage the patient having an abnormal cornea. So Olsen formula, which is another one with the ray tracing one, it is considering as a C constant. C constant, it is based only where the lens will be positioned in the capsular bag. So it is a C constant, depends on the crystalline lens anatomy. It is independent of the reading and the axial length. So it is more effective in the post-LASIK formulas. Another formula which is coming up is the EVO formula based on the theory of the emetropia factor. It is very good calculator. It has option for the post-myopic LASIK or PRK also. It is also two-part important in the toric calculator. EVO toric calculator is now emerging as a newer toric calculator which is considered as a better than the Barrett one, because it has a theoretical posterior corneal astigmatism prediction and it has a thin lens modeling of different types. And CAN formula, it is also one of the very good coming up formula which has a thick lens formula and which has a gender variables. Just briefly going for, because I am out of time, Paul DGS calculator, which is also a artificial intelligence and the optics based calculator which has a very good results in the history of post-refractive corneal surgery patients. And the T2 formula, those who are using still SRK-T, this is another formula which should be downloaded. It can be downloaded easily on your desktop and it gives nearly 10% more accuracy than what your SRK-T is giving. Thanks for your attention.